In this video, we are going to be looking at the topic Achalasia. Hi, I'm Sharon. I'm working as an assistant professor at MMM College of Nursing. The following are the objectives that we'll be addressing in this video with regard to the topic Achalasia. Achalasia cardia is a rare chronic disorder. It is one of the esophageal motility disorders. It is defined as the absent or ineffective peristalsis of the distal esophagus, that is the lower two-thirds, accompanied by failure of the lower esophageal sphincter, LES, to relax in response to swallowing. Narrowing of the esophagus just above the stomach results in a gradually increasing dilatation of the esophagus in the upper chest. There can also be a selective loss of inhibitory neurons, resulting in unopposed contraction of the LES. Achalasia may progress slowly and occurs most often in people 40 years of age or older. The causes of esophageal motility disorders are divided into four categories. The first one is skeletal muscle dysfunction. The second one is pharyngeal paralysis, otherwise referred to as transfer dysphagia. Affected transfer from pharynx to esophagus is the third one, and the topic that we are dealing with currently, that is Achalasia cardia, is the fourth one. Looking at the etiology, the exact cause is not known, and that is referred to as idiopathic achalasia. Causes for secondary achalasia are carcinoma of stomach, which is due to the esophageal infiltration of the tumor, eosinophilic gastroenteritis, Chagas disease, which is an infection that is caused by Trypanosoma cruzi, which is a parasite. Lymphoma, drugs. Common examples are opiates and antibiotics, bariatric surgery, otherwise referred to as weight loss surgery, and neurodegenerative disorders. Let's look at the epidemiology of achalasia. There is an annual incidence of roughly 1 per 1 lakh people and a prevalence of 10 per 1 lakh, and it does not predominantly affect a particular age, race, or gender. However, a recent study showed increasing hospitalizations and associated costs for achalasia over the last 16 years in the United States, with a disproportionate increase in patients under 65 years of age and racial minorities. For some unknown reason, the incidence of achalasia increases in individuals with spinal cord injury, but these cases typically relate to damage of the cervical and thoracic vertebrae. Altered esophageal motility, similar to achalasia, is also observed in individuals with anorexia nervosa. There are reports of achalasia after the use of endoscopic sclerotherapy for varices. The higher the number of sclerotherapy sessions, the greater the risk of achalasia. Most of these patients will show hypotensive peristalsis and defective lower esophageal sphincter function. Outside the United States, the rates of achalasia vary from 0.1 to 1 per 1 lakh people per year. Studies show that relapse rates are higher if the initial treatment was pneumatic dilatation. However, complications have been noted to be much higher in patients who underwent a helemyotomy compared to those who underwent pneumatic dilatation. Achalasia occurs with equal frequency in both males and females. The disorder typically affects people between the second to the fifth decade of life, with a peak incidence between the ages of 30 to 60 years. Overall, less than 2 to 5% of cases occur in children less than age 16. Before we go into the classification of achalasia, we need to understand the Chicago classification of esophageal motility disorders. So, the first thing that we need to be aware is about the median integrated relaxation pressure, otherwise referred to as IRP, which is normal between 0 and 15 mm of Hg. And this is determined by using high resolution manometry. And when the median IRP is increased, the conditions they represent include esophagogastric obstruction disorder, achalasia cardia, and esophagogastric outlet blockage. And if the median IRP is normal, There can also be other disorders such as peristalsis disorders, diffuse esophageal spasm, nutcracker esophagus, and jackhammer esophagus, so which are actually hypercontractile esophagus. And understanding this helps us to understand the classification of Achalasia cardia. So there are three types of achalasia cardia. The first one is referred to as classical achalasia. And here the esophagus muscles barely contract, so the food moves down because of gravity alone. Type 2 achalasia, here the pressure builds up in the esophagus, causing it to become compressed. So this is the most common type and often causes more severe symptoms than type 1. Type 3 achalasia is otherwise called spastic achalasia or vigorous achalasia because of its severity. And here there are abnormal contractions at the bottom of the esophagus where it meets the stomach. And the contractions can cause chest pain that can awaken a person even from sleep and imitate the symptoms of a heart attack. Pathology of achalasia. It is usually insidious in onset. The neurons in the esophageal meningeal plexus are lost. This condition is thought to be caused by an autoimmune process, and environmental variables are also included. HSV1 is known to have a strong correlation with the viruses. Genetic elements such as human leukocyte antigen DQ alpha 1 0103 and human leukocyte antigen DQ beta 1 0603 and abnormal autoimmune responses, cytotoxic T cell activation, ganglionitis, and neuronal death can also play a part in the cause and pathology of achalasia cardia. Let's look at the pathogenesis and clinical findings of achalasia. So before we move into that, we need to be aware about few abbreviations. First one being LES, that is lower esophageal sphincter. Second one EMP, that is esophageal meningeal plexus. And the third one NO, referring to nitric oxide. So we'll be dealing with two achalasias, that is primary as well as secondary, which is otherwise referred to as pseudo achalasia. So starting with the primary, it can be because of an unknown or idiopathic cause that leads to recruitment of neutrophils and eosinophils to the EMP, and that causes inflammatory degradation of inhibitory nitric oxide producing neurons. And this causes two pathways. The first one being inappropriate contraction of the smooth muscle in distal esophagus, leading to loss of peristalsis in distal esophagus. The second pathway shows cholinergic neurons involved in the low esophageal sphincter tone are relatively spared, causing incomplete relaxation of low esophageal sphincter. Now, when it comes to the secondary achalasia, as discussed earlier, we have multiple causes. And let's look at the first cause, that is Chagas disease. This is caused by a blood-borne parasite, that is Trypanosoma cruzi. And this parasitic invasion leads to inflammation of the esophagus. The second cause that is addressed here is tumor, and it can be because of esophageal carcinoma, lung cancer, cancer of the gastric cardia, etc., which causes local invasion of EMP. And the third cause is diabetes mellitus, and that causes chronic hyperglycemia, which damages the autonomic nerves, leading to autonomic neuropathy involving the EMP. All these three can lead to dysfunction of the esophageal meningeal plexus and thereby causing secondary achalasia. Now let's look into the clinical manifestations. And so what initially happens is there is lack of ileus relaxation, making it difficult for the food and the water to pass through, and thereby this puts pressure on the esophagus, causing a sense of fullness. And if we look at the X-ray, especially the barium swallow, we can see bird's beak sign, which is characteristic of achalasia. And this ileus relaxation lack can also cause dysphagia, that is difficulty in swallowing both solids as well as liquids, and leading to decreased caloric intake as well as weight loss. The next one is regurgitation of undigested food that can cause stomach acid irritation of the esophagus and leading to heartburn. And this can be seen in the epigastric as well as the retrosternal region. And this regurgitation further can also cause decreased caloric intake and weight loss. Further, we also see that the lack of ileus relaxation can cause lack of peristalsis, elevated ileus pressure, which can be seen on an esophageal manometry. And this food intake, okay, which puts pressure on the esophagus, may be aspirated into the lungs, and that can end up causing other diseases such as pneumonia and asphyxiation. It can also cause pneumonitis and chronic cough. Let's address the remaining clinical manifestations that were not discussed in the previous slide, such as burping, nighttime coughing. Patient can also have vomiting, as well as chest pain that comes and goes, which we discussed in the type 3 classification of achalasia, which is otherwise referred to as spastic or vigorous achalasia, where, as said earlier, the patient can even wake up from the sleep because of the pain, and it can mimic a heart attack. Here, we are going to see how to grade achalasia on the basis of the clinical severity, and this is done by the Eckhart score. So, the symptoms that are taken into account are dysphagia, regurgitation, retrosternal pain, and weight loss in kg. It's graded from 0 to 3, 0 being the lowest and 3 being the highest. Let's look at each in detail. So, score 0 stands for no dysphagia, regurgitation, retrosternal pain, or weight loss. 1 shows occasional dysphagia, regurgitation, and retrosternal pain with less than 5 kg weight loss. And 2 shows daily dysphagia, regurgitation, retrosternal pain with 5 to 10 kg of weight loss. And 3 shows dysphagia with each meal, regurgitation, as well as retrosternal pain with more than 10 kg weight loss. And moving on, you can grade based on level 1, which gives a score of 2 to 3, level 2 giving a score of 4 to 6, level 3 giving a score of more than 6. 0 to 1 is known as level 0 achalasia cardia. The remaining part of achalasia will be covered in the next video. The following are the references. Thank you.